Welcome, everybody. Thank you for joining us for Psychiatry Grand Rounds series. It is my pleasure today to have the opportunity to introduce the first of our two speakers for our session. And in the interest of time, I'm going to be brief so that they both have an opportunity to present all of the materials that they have prepared for us today. Catherine Canner obtained her Bachelor's of Art from Duke University with a major in Women's Studies and minor in Religion. She fulfilled her pre-medicine requirements and then attended Albert Einstein College of Medicine in New York. She started a residency in psychiatry at Montefiore Medical Center, Department of Psychiatry, when she completed the first 2 years of training. We were lucky enough that she then had to move to Tucson, where she joined the University of Arizona residency program, and she's expected to complete the remainder of her training in the next month. She has an interest in women's mental health and has spent some time shadowing Dr. Kathy Smith, who's one of our local women's mental health experts and child psychiatrists. And she also has worked with Dr. Mark Gilbert at the Cancer Center and with his mind-body groups for infertility and chronic illnesses. After graduation, Catherine will be moving to Phoenix when, again, her husband is going to be completing his medical training, and she'll be working at the St. Joseph's Hospital as an outpatient psychiatrist. And she's worked hard as a resident and now looking forward to have an opportunity to be a mother of three, family woman, and an attending psychiatrist. So today, Catherine is going to talk to us about considerations regarding the pregnant patient in your outpatient psychiatry practice. Please help me welcome her.
Thanks, Dr. Moreno. So in deciding on a topic for my grand rounds, a particular patient came to mind. And this is a patient I've been seeing for almost 2 years now. And one day, she spontaneously announced to me that she just learned that she was well into her second trimester of pregnancy. And I'd been prescribing her SSRIs and benzos. And so she abruptly stopped the medication prior to informing me. And I kind of, at the time, didn't know much about it, and so agreed with her plan. And then after the fact, went back and looked up some of the data about, was this a good idea to have stopped her medication or not? And as it turned out, it probably was not the best idea for this particular patient. And so this is an important conversation to talk about because 50 to 60% of pregnancies are unintended. And so this will happen to you in your outpatient practice. So today I'm going to talk about some background data on depressive disorder and pregnancy, briefly go over the FDA category designations for pregnancy, and talk about their limitations and how we can't completely rely on the designations, and then discuss the two sides of the discussion, the risks of untreated depression on a pregnancy and a baby, and the risks of pharmacologically treated depression with SSRIs. And then at the end, I'll give you some resources. This really is, I guess, designed for practitioners. So you'll have some resources to hand out to your patients and also for yourselves. So 14 to 23% of pregnant women will experience depressive symptoms at some point throughout their pregnancy. And a study in 2004 found that between 25 and 35% of perinatal women, that includes postpartum, with a current psychiatric mood or anxiety disorder were found to be receiving or had received mental health treatment. So a lot of patients are going untreated. However, in 2003, 13% of women who took an antidepressant at some point during pregnancy, and this is a doubled statistic since 1999. So more are being treated today than they were in the past, but it's still really not enough. And the most vulnerable populations are women with histories of depression who abruptly, like my patient, stop their psychotropic medication upon learning that they're pregnant. And these women have a significantly increased risk, and I'll show you that paper. So this is a paper in JAMA in 2006 by Lee Cohen, and it was a prospective investigation which basically did psychiatric assessments on a monthly basis across the span of pregnancies. There were 201 pregnant women enrolled, and they recorded not only the number of relapses, but the time to relapse. And all these women had a history of MDD. They all were less than 16 weeks gestation, so early in their pregnancy, and they've all been euthymic for at least 3 months prior to conceiving, and were all on antidepressant treatment. And this is a paper that's quoted a lot. Out of all of these women, 43% experienced a relapse. That's the total relapse rate. But of the women who were maintained on medication, only 26 experienced a relapse versus the 65 women who discontinued medication, 68% relapsed. So it's a very significant. P is less than 0.001 for the women who discontinued their medication to relapse. 50% of them relapsed in the first trimester, and 90% relapsed by the end of the second trimester. And that's probably the highest statistic I'll give you today about the risks. So brief overview of the FDA category designations. These were published in 1975. They're A, B, C, D, and X. And all of the designations occur in the absence of pregnancy data. So that's the first limitation. They are published when the drug is released. So whatever data is out there when the drug is released is what they are assigned with. If new data comes out after the fact, it's very rare that a category will be moved up to like a more permissible designation. Rather, if data comes out showing that it's risky, it's more likely that the drug will be classified as from a C to a D. But it's rare that it will ever go back to a C. And this is really because the drug companies are concerned about litigation. So the risks of the untreated illness are never taken into account, and the risks of the severity of the illness and recurrence are never taken into account. So a lot of people do not pay too much credence to these designations. So A, we're not concerned about because none of the psychotropic medications are A. None of them are B as far as I know either. Those are more permissible medications in pregnancy. C is what all the SSRIs are, except for Paxil, which was changed to a D, and D is what all the benzos are. And so C basically means that either studies in animals have revealed adverse effects on the fetus, and there are no controlled studies in women, or the studies in women and animals are not available. So risk cannot be ruled out. And this is where we fall into a lot of our medications, as well as D. There is positive evidence of human fetal risk, but the benefits from use in pregnant women may be acceptable despite the risk. And benzos are in this category not because they're fatal or anything in the newborn, but because they cause sedation. And X is contraindicated, and you all know examples of X like thalidomide. Okay, so the data on the risks of untreated depression. Untreated depression may be, these women who aren't treated for their depression may be less likely to receive adequate prenatal care. I think that's kind of obvious because they're not as able to take good care of themselves, so they're not going to be taking good care of the pregnancy. This may negatively affect maternal weight gain, which can affect the pregnancy. They may be more likely to use alcohol, tobacco, and other known substances that are clearly Category X. Pregnancy complications are more common in untreated depression. For example, there's more nausea and vomiting reported, there's more hyperemesis gravidarum reported, more cases of preeclampsia, and there may be an increased risk of low birth weight, prematurity, and fetal growth retardation. All these things are they're not definitive because some studies show a relationship and other studies don't. And the numbers of women are small in all of these studies. So across the board, the numbers in the studies are lower than in many other drug studies because of the nature of the situation, that we can't give all pregnant women one drug and do a randomized control study the way it's just not ethical. So those are the risks to the fetus of untreated depression. They've been noted to have some behavioral differences when they're born. For example, increased irritability, decreased activity and attentiveness, and fewer facial expressions compared to offspring born to mothers without depression. And this was interesting to me because one of the big risks that I'll show you on the SSRI side are an increased risk of irritability and withdrawal behaviors in the neonate. So it's almost like either way, if the patient has active depression or is on an SSRI, there is going to be, there's a higher risk of some sort of a behavioral syndrome in the neonate. In small studies, they found that newborns of depressed women have physiologic profiles that parallel those of their mothers. For example, elevated cortisol, decreased peripheral levels of dopamine and serotonin, and some other findings. And there are conflicting reports of long-term effects of offspring of mothers who were depressed during their pregnancies. But I think this quote really says it all. If mama ain't happy, ain't nobody happy. And I think everybody knows this is true, whether you're a mother or you've lived with a mother. So the risk of untreated depression for a newborn is tremendous. So now I'm going to talk a little bit about the risks of medication exposure. So any drug administered to a mother while she's pregnant is going to cross the placenta to some extent. There used to be a belief that the placenta somehow blocked transmit of certain medications, but not others. But that's been disproven. There are three major categories of risk to the fetus. There's the risk of teratogenesis, which I'll discuss, the risk of neonatal toxicity, so high drug levels in the neonate when they're born, or withdrawal from the drug in the neonate, and then long-term neurobehavioral sequelae. So starting with the risk of teratogenesis, it's important to know when certain organs are developed, because then you can know when to prescribe and when not to prescribe. So a teratogen is any agent that interferes with development and can lead to organ malformation or dysfunction. There's a baseline incidence of major congenital malformations in the newborns in the United States that is estimated to be 2 to 4%, and some say 3 to 5%, so no one is starting at zero risk. So the question is really, are the drugs we're prescribing increasing the risk from above this baseline? And in many cases, the answer is no, but we'll talk about it. So different things are formed at different stages. Implantation in placentas, 4th week, brain, spinal cord, primitive heart begin to form in the 5th week, but they're completely formed by the 9th week. Neural tube folding and closure, which form the brain and the spinal cord, are the 6th week, and the palate is between 6 and 8 weeks gestation. And that comes into play when we discuss benzos, which I'm probably not going to do today. But so the risk of teratogenesis, lots and lots of studies have been done about this. It was hard to pick which ones to discuss, but many of them showed no increased risk of major congenital malformations in exposed infants, although Paxil does seem to be an outlier, so I'll talk about Paxil. First trimester exposure to Paxil was associated with a 2-fold increased risk of cardiac defects, specifically atrial septal defects and ventricular septal defects. And this caused the FDA to change the category assignment from a C to a D. However, and I'll show you that study, there was a more recent study that did not show an increased risk with Paxil, and this category assignment was not reverted back to a C. So this is a paper in the New England Journal of Medicine, 2007, called First Trimester Use of SSRIs and the Risk of Birth Defects. The overall use of SSRIs was not associated with significantly increased risk, and they did look at over 9,000 infants with birth defects. There were 3 specific defects that they were looking at because they had been reported in the literature as showing a relationship, and those 3 are craniosynostosis, omphallocele, which is an abdominal wall defect, and defects. So Overall, there was no increased risk. However, when they were looking at individual SSRIs, they did find a relationship between, as you can see on the bottom left, sertraline and omphalocele, sertraline and heart septal defects, and paroxetine and certain heart defects. These were statistically significant, but if you look at the numbers of exposed subjects, it was extremely low. And so the kind of analysis at the end of this paper says to take this into consideration, but that this paper can't be used to guide treatment in any meaningful way because just the numbers were so little. So these are all rare outcomes to begin with, which makes it difficult to prove that there's an association. This is a study in Sweden published in 2007 that is called Maternal Use of SSRIs in Early Pregnancy and Infant Congenital Malformations. Over 6,000 women who reported SSRI use in early pregnancy were followed, and I believe actually they looked retrospectively. So the women already had the congenital babies with congenital malformations, and then they were asked to report from before what they had remembered taking, which always has this recall bias problem. And there was no general increase in malformation risk found there, except for paroxetine, which did show an increased risk from 1% to 2%. Again, small risk when you look at the big picture, but like a doubling of the effect. And this was the paper that more recent than the previous one that showed that Paxil is actually safe in pregnancy, and there was no association between Paxil and any cardiac defects. And that in both groups, the exposed and the non-exposed, there were the risk of cardiac defects in paroxetine was 0.7, and the baseline we said is 1% of cardiac defects, so not above the baseline. These women in this study were on a dose of Paxil of 20 milligrams or less, so possibly, and a dose response analysis was not performed, so it's possible that the dose has something to do with the risk. Also in this study, they only took into account the patients with severe heart defects. So all the minor heart defects that went unnoticed by the pediatricians early on that had no kind of symptoms, the kids were doing fine, were not part of this report. So teratogenicity was a big concern. It seems like the most prevalent data is that it's not to change our prescribing practices significantly. Another big concern is something called persistent pulmonary hypertension of the newborn, and this is a later concern. So SSRI exposure after 20 weeks was shown to have, in this paper, a statistically significant association with PPHN in the newborn. So this was not the case for SSRIs prescribed before 20 weeks of pregnancy, and this was not found to be the case with non-SSRI medications. Only with SSRIs after 20 weeks did this association show to be significant. And again, it's how you describe this to your patients. So it looks like the risk, I think it triples, if not is 6 times as much. There's a range. However, it's a very, very very rare event. So the absolute risk is still extremely low. It's just under 1%. So if you describe it to your patients as the risk is 6 times as much, nobody's going to take the medication. But if you describe it as 99% of women exposed to an SSRI after 20 weeks of pregnancy will deliver an infant without this disorder, it sort of depends, they might think differently about it. You're not lying to them, you're just presenting the data in a, actually, I think maybe more realistic way. And the thing is, though, with PPHN is that it can be very benign, and it can also be fatal. So you have to kind of explain the syndrome to the patient. And the severe cases are 10 to 20% of the total cases. So neonatal toxicity is or perinatal syndromes, they call it. Now they're starting to call it poor neonatal adaptation, is a very high likelihood in women who are taking SSRIs later in their pregnancy. And this is found to actually occur in 30% of neonates, and I'll show you the paper that showed that. But it's unclear whether these babies are toxic at birth or withdrawing from a drug at birth, and it's possible that they're initially toxic and then withdrawing, and the spectrum includes all of that. The syndrome includes irritability, tremor, GI or sleep disturbances, hypertonicity, trouble feeding, tachypnea, convulsions, sweating, fever. So it's not a pleasant thing for a mother of a newborn to have to deal with a baby with all of these symptoms. And it can be very stressful, and it is 30% of newborns who will have this. So this should be really discussed at length with your patient. Most commonly reported with paroxetine and fluoxetine. So this just is the paper in 2006 that described the 30% number. None of these babies required any treatment. None of them were sick beyond or had symptoms beyond 2 weeks. But and the peak of the symptoms was 48 hours after birth. But it can be stressful, so worth talking about. And this paper looked at 120 infants. 60 were prolonged to SSRIs, either in the entire pregnancy or at least the 3rd trimester. And they had this special score that they used to rate how severe the syndrome was. And the ones exposed to SSRIs had either severe or mild syndromes, but all non-exposed neonates had a score of 0. So clearly there's a relationship. Long-term neurobehavioral sequelae are subtle, may not present immediately, and very early in research. So I don't know much about long-term sequelae of SSRIs, and it just very superficially what I read was that none have been picked up in terms of IQs, but they looked at preschool kids. So putting all of this together, the risks of treating depression and the risks of a depression on the neonate, there are some joint recommendations made by the American Psychiatric Association and the American College of Obstetrics and Gynecology that came out in, I think, 2009 that showed for mild to moderate depression to start initiating therapy with psychotherapy, not medication management, and CBT or interpersonal therapies are recommended, and then focusing on the lifestyle changes, everything from nutrition to weight management to prenatal care to childbirth education, planning ahead for when the baby comes, recruiting support, minimizing risky behaviors. For more severe major depressive disorder, medication does remain first line based on the data that we have available today, assuming that you've done the risk discussion with the patient and that you've really worked on documenting the patient's exposures, because antidepressants are one of million of exposures, and it's important that, if there, God forbid, is a bad outcome, that you've spoken to the patient about other possible variables. So document any drugs or environmental exposures that they might have taken since conception. And encourage pre-pregnancy planning, but like I said, 50 to 60% of pregnancies are not planned, so you don't have the liberty of doing this with most people. In a patient who you are planning pre-pregnancy, it's suggested that you encourage a period of euthymia. A year would be ideal, but not necessarily. Many women don't have that kind of liberty. And also, we don't know exactly when they're going to become pregnant. So just to encourage some period of euthymia is recommended. Some people would consider slow tapering and continuing the medication with close monitoring before pregnancy for a patient who has their depressions in the past have not been so severe, they've not been suicidal. And then most importantly, take into consideration the patient's preferences, because most patients will have a very strong opinion one way or the other, whether they want to take medication or not during their pregnancy. So in the interest of time, I'm not going to go into all of these algorithms, but they are very good algorithms put out by the APA and the ACOG, and they talk about each different type of patient you might encounter. So like the patient who's contemplating pregnancy and is undergoing treatment for depression is this algorithm. The patient who's in an episode of depression who is pregnant and not taking antidepressants has this algorithm, and the patient with depression who is pregnant and currently taking antidepressants is in this category. And most of the decision tree is based on like how severe their depression is. Have they responded to therapy in the past? Have they responded to meds in the past? It seems like a lot of the papers I read do not recommend changing medications in pregnancy. If something is working, to stick with it and just to discuss the risks really clearly. The resources that are very, very helpful, that were helpful for me in preparing this talk and that could be helpful for you if you have a patient who becomes pregnant or is planning a pregnancy, are the ones I have listed here. You can call these numbers and leave a message, and you will get a phone call back within 24 hours regarding any medication you're thinking of prescribing during pregnancy. You'll get the data from an expert, genetic counselor on, what's not safe about it and what the likelihood of a poor outcome is. And Dee Quinn is really, really excellent. So these are good resources. And she also has a website, otispregnancy.org, where you can actually print out a fact sheet and hand it to your patient, and it will say, one for Paxil or one for fluoxetine, and it will say, it will have commonly asked questions like, when is the drug out of my body from the time I stop taking it, for a woman who's pre-pregnancy planning and doesn't want any medication. So to keep these resources in mind. So thank you, and I'm open for questions.
One question?
Okay. Go ahead.
Do you think there's a role for RTMS in treatment of depression during pregnancy?
I heard someone ask Marlene Freeman that, actually, at the Psychopharm conference, and she's really the expert on this subject. And she didn't. I remember she didn't specifically answer that there's any studies on the subject. So someone asked about why am I blanking on the term? The other non-medication treatment for depression. Yeah. And she said that she hasn't been recommending it, but there's no data, as far as I know. That was like 6 months ago.
I'm sorry, what was the other one?
Vienna? Vagal nerve stimulation?
Yeah, that takes like months or years.
So, I don't know.
Okay.
Thank you.
Thanks again, Catherine. And I don't know how we're going to be doing this change in this, but let me go ahead and start introducing Dr. Keaton Dioris. Keaton obtained his Bachelor's of Science from The Ohio State University. We have some Hawkeyes out here. He had majors in psychology, economics, and a minor of English. He received honors, summa cum laude, and he then attended the University of Toledo College of Medicine, where he also was distinguished as receiving the Psychiatrist Award for his graduating class. Then he came to the University of Arizona, and during his residency program, he has done a really nice job in all of his rotations. He's also done really a stellar job with his standardized test, the PRIDE exams. He's tested in the upper 90 percentiles, which is a nice endorsement of course, everything that he's heard in grand rounds that stuck with him and has helped him through some of those pieces. He has been involved, of course, received multiple honors and distinctions. He's also been involved in teaching and in leadership roles here at the Department of Psychiatry. He's the present chief resident. Has been involved in research as well, including his collaboration with some of our sleep researchers excuse me, in our department, and led to his paper on using actigraphy to measure the effects of selective serotonin reuptake inhibitors on night-to-night variability in awakenings. This paper earned him also an award at the National Meeting of the American Academy for Sleep Medicine as the Insomnia Section Investigator Award in 2010. So in a related presentation today, he will be talking to us about strange bedfellows, antidepressants, and sleep. Please help me welcome Keaton.
Thank you. Thanks, Dr. Moreno, and thanks everyone for coming. So when I chose this title, Strange Bedfellows, initially I was thinking maybe I'll look at the use of propofol for insomnia. But as I reviewed the literature, I really only came across one case of that, and so scrapped that idea. But as I looked more at antidepressants, I found that they're pretty quirky in how they work on sleep as well. So it's still pretty applicable. So my talk, I'm going to start with looking at some basic sleep physiology tenets and how the antidepressants work with them. Then I'm going to look at how sleep parameters play into psychiatric disorders. And finally, I'll focus on the study I was involved in with Dr. Haynes. So I'm sure most of you have seen this sleep staging slide before. This is of kind of an average young adult sleep cycle over the night. A couple of things to take away from this. These black shaded bars are REM, when we're dreaming. And you'll see that they occur every 60 to 90 minutes, and they progress as the night goes on. We have more in the early morning. These other stages, 1 through 4, are called non-REM. And 1 is probably what you guys are feeling now, just about to fall asleep. And 3 and 4 are known as the delta wave sleep, the slow wave. These are thought to be the most restorative stages of sleep. And if people don't get them, they complain of a subjective sense of fatigue they found in studies. So those are kind of the main tenets of that. Now I'm going to look at the TCAs and sleep. My focus on this talk is primarily the SSRIs, but I just wanted to at least summarize some of the general findings for these. So amitriptyline, imipramine, doxepin, and trimipramine have been studied the most. And in general, tricyclics show these trends. Decreased sleep latency, meaning the time it takes to fall asleep, increased total sleep time overnight, and then decreased REM. And we're not exactly sure of the implications of decreased REM because it's been kind of controversial. But we do know that clomipramine decreases REM the most, and trimipramine decreases it the least. But we're still trying to figure out what that means. But just even though SSRIs are kind of our primary line nowadays, just to let you know, in the past year they've been marketing doxepin, a classical tricyclic, under the patent of Silenor quite heavily. And just at the recent APA, they had a huge booth set up just for Silenor to treat insomnia. When we turn to the MAOIs, there's very little actually written. There haven't been very good placebo-controlled studies. The classic ones almost completely take out our REM cycles over the course of a night. So there's pretty much no active dreaming. They also decrease our total sleep time. And there's significant side effects with insomnia, up to 62%, and daytime sedation, up to 42%. The selectable reversible MAOIs, it's really just a mixed bag. There haven't been good studies establishing one way or the other what's happening. So now I'm going to look at the SSRIs, which, like I said, are the main focus of this talk. They're primarily working, we think, on the 5-HT1A and 5-HT2 receptors. And initially they thought, well, the serotonin is really acting to, in our states of sleeping. But the more recent studies kind of show that it's actually the opposite, that it's playing a role in when we're awake. So our normal assumption is, well, we use SSRIs on people and we treat their depression and anxiety, and we should be improving their sleep by taking care of those disorders. But it's not that simple, because up to 25% of people taking SSRIs still note sleep disturbances even after their mood has improved. And the rates of insomnia on SSRIs have ranged from 5 to 35%. So what we often do to treat this is we start using a benzo or trazodone. But there's actually a whole host of sleep disturbances that have been found with SSRIs in the literature. So one is increased sleep latency, meaning it takes more time to fall asleep. Another is decreased total sleep time, decreased REM, periodic limb movements throughout the night. Interference with slow-wave sleep has been found in some studies, not all, but we talked about slow-wave sleep being that nice, deep, restorative sleep, and then increased awakenings, which was what our study was looking at. As far as how serotonin, we think, now is functioning in sleep, we know that the median and dorsal raphe nuclei are where the major serotonergic fibers are, and that's going to innervate much of the CNS. The serotonergic neurons are active in waking, less active during non-REM, and pretty much inactive during REM. So as we aggregate all the pathways, it looks like serotonin is just inhibiting the REM-producing cells. So now I'm turning to the part of the talk where we're looking at sleep parameters in psychiatric disorders. And we know from our practice that SSRIs are typically the first-line medication treatments in depression and PTSD, especially in terms of biological treatments. Our study was looking specifically at VA. The majority of clientele were from the VA. And this population has a very large comorbidity of PTSD and depression. And so as we reviewed this literature, we saw there's not a lot of, we didn't really see anything using actigraphy to look at the sleep disturbances with SSRIs in people who had comorbid PTSD and depression. So this is a little bit about PSG and actigraphy. When they do a sleep study, the typical, what they do is polysomnography, also known as PSG. And in these studies with SSRIs, they have people come in and usually sleep for just overnight, one night, sometimes two, but it's usually like a one-and-done type thing. And that can be useful, but we know from other studies that when there's insomnia associated with depression or PTSD, there's actually a lot of variability from night to night. And PSGs won't always catch that because we're using them for such a short amount of time. We've also seen this variability with people who have depression in their night-to-night sleep. So in these cases, actigraphy can be a little bit more useful because we can monitor people's sleep for days to weeks if we want to. So the studies that have been done looking at actigraphy and PTSD and MDD, they've looked individually at depression and PTSD, and they found that in depression, there's increased nocturnal motor activity and decreased total sleep time. And the PTSD findings are mixed. There were two studies saying there was really no difference when we looked at actigraphy, but there was one study which showed that people actually woke up more than they thought they did when they self-reported in the sleep diary. So our study, the primary goal was trying to look at, from night to night, what the variability is like in awakenings and other parameters that look at wakefulness among people who take SSRIs versus those who aren't, and we were using actigraphy. And then a secondary goal, we were looking at just the averages, of course, across the period of time. So our design, we used a cross-sectional analysis from treatment studies on patients. They had comorbid PTSD and depression. They were recruited from the Southern Arizona VA, the majority of them. There were a few from community clinics as well. And I'm not going to go through all the exclusion criteria, but some of the things to keep in mind is these people were screened to make sure that they had not been abusing substances in the past 30 days, and they were also screened to make sure that they didn't have a primary sleep disorder already going into the study. To ensure this, we used, to screen who had depression and PTSD, we used the SCID, and as the SCID was being performed, we also had our researchers collect their antidepressant lists and reconcile it with the list of antidepressants we had on hand. To monitor the severity of their symptoms, we used the PTSD checklist, which has been validated in a lot of studies, especially through the VA. And then as far as measuring the actigraphy, we used the ActiWatch, which is down here. It's a little picture of what an ActiWatch looks like. And the mean that people wore this ActiWatch was about 5.5 nights. And the things that we looked at as far as outcomes were how many times they would wake up, a term in sleep literature known as WASO, which means the amount of time they spent awake after the onset of sleep, and then the percent of time that's spent awake after sleep. And these were the ones that were found to be significant. And ANOVA techniques were used as far as the statistical analyses. This is some of the demographics of the participants. You can see that we had a pretty even number on the SSRIs versus people who weren't taking SSRIs. Age was pretty similar as well. Being primarily recruited from the VA, these were mostly males, as well as primarily Caucasian and mainly vets. And then the PCL score, which we were using to track their PTSD symptoms, you can see it was slightly higher in the SSRI group, which you would expect that if people had more severe PTSD, they'd be prescribed SSRIs. And then we ran chi-square analyses on these and saw that there were no statistically significant differences between the two groups in any of these measures. So these were our results. First thing you're looking at here is the number of awakenings across a night. And this is a mean average. So you can see the group who was not on an SSRI were down about 24 awakenings per night on average, whereas the SSRI group was close to 39. So a pretty significant difference, about 15 more awakenings per night on average. Now this is turning to what we were really looking at, which is the night-to-night variation. And to measure this, we looked at the standard deviation in the two groups. And you can see there's also a significant difference here in the patients who were on SSRIs versus those who weren't on SSRIs. There's a lot greater variation that they're having from one night to the next in how many awakenings they're going through. And then these are, again, going back to the means, the term I had talked about before, WASO, wake after sleep onset. You can see that they're spending, on average, the SSRI group, about 20 more minutes up throughout the course of the night. And they're a little bit over 12% of the night that they're up as well, compared to almost 9% in the non-SSRI group, which was significant with a p-value of 0.04. And then again, we turn to the night-to-night variation, looking at the standard deviations. And we see that WASO was associated with significantly more variation from one night to the next in the SSRI group. And the percent of time that they were awake was also associated with much more variation. So in summary, we know that individuals prescribed SSRIs experienced, on average, more frequent awakenings, more wake time after the onset of sleep, and more time awake in bed. And then, in addition, looking at the nightly variation, the standard deviations, we saw that there was also an increase in those measures in the number of awakenings, WASO, and the percentage of time spent awake in bed. So our conclusions were that this study was extending and confirming PSG findings that show that SSRI use can contribute to fragmented sleep. And specifically, using actigraphy, which let us record over more nights, helped to elucidate some of the nightly variation in wakefulness associated with SSRIs. From a behavioral perspective, SSRIs may additionally hinder patients' abilities to establish a routine sleep-wake pattern. Seem to be some technical difficulties here. So if you think about it, something that's very disruptive to sleep, we can adapt to if we're expecting it, or if it becomes a routine. And as an example, here's something we would think is disruptive to sleep: water, that this baby actually has adapted to because it's predictable and routine and actually likes.
Turn off the water. She wakes up to turn it back on.
You've heard of Pavlov's dog. This is Pavlov's daughter.
So as you guys can see, this baby actually needs the water to fall back to sleep. And the point of this is just that if we're having that much night-to-night variation when we're on SSRIs, we really never know what to expect from one night to the next. So we need predictability. So some of the considerations and limitations of this study, well, it was a cross-sectional design and we didn't do a controlled trial. There were other sedating medications involved as well as SNRIs. And these were all, the SNRI people in the study were actually placed in the non-SSRI group. So I'm guessing we'd actually probably have more robust results if we place them in the SSRI group. Because from what the literature has shown, SNRIs can be some of the most disruptive to sleep. The few studies that have been done on venlafaxine show actually a lot more awakenings than any of the SSRIs. And then something very common in any of the sleep studies, looking at sleep diaries versus sleep parameters. So any of these studies that were done with SSRIs, we'll see all these differences in the WASO and percent of time spent awake. And then there's sometimes a discrepancy between those measures and patients' subjective reports of sleep in their sleep diaries. They might have had this many awakenings, but actually they say, well, the sleep wasn't that bad when they think about it. And then specifically with the SSRIs, we're now going back through the data and trying to assess what were these vets' compliance like with the SSRIs. Is there a dosing effect? Not a whole lot of studies had really addressed that. The timing, are they taking it in the morning or at night right before they go to bed, would be important to know. And duration, this is something else that wasn't really studied much with the previous papers, whether there's an effect of how long they've been on an SSRI and they learn to adapt to whatever disturbances is causing in sleep. Clinically, so we know that SSRIs demonstrate the potential for sleep disruption, and there's even been papers saying that once mood has stabilized from SSRIs, that about 35% of the time sleep difficulties can still persist. So what do we do? Right now, the common standard is, well, we just throw a benzo on there, throw trazodone in, and try to address it that way. Which works a lot of times, but we know with benzos, especially in the elderly, we always have to worry about cognitive problems, falls, and it's not a completely negligible risk of dependence and tolerance as well. Trazodone, it's less likely that they're getting acclimated to it, but as we go up on doses, we might have issues with kind of this drowsiness, hangover effect, as well as dizziness. And then there have been studies looking at, more recently, using olanzapine to try to treat some of these sleep disturbances, which has been successful, but having someone on a long-term antipsychotic for sleep with all the risks of metabolic issues is also something we have to think about. So I think it points to the need that for novel medications to address this arena of depression and sleep disturbances. And we've got some coming out in the market. We'll have to see how they do. One is agomelatine, which is being used in Europe right now, which works on the serotonin receptor, but also 2 melatonin receptors as well. And so that's something we'll have to watch. I kind of worry that they've put a warning already that you need to monitor liver transaminases with it. So I don't know if that'll, I'm guessing it will affect how much it's used. And then another one on the market, which has been released, is vilazodone, similar to Serzone, which is kind of looking at the serotonin antagonism as well as some partial serotonin agonism. So we'll have to see if that helps with sleep at all. I think it also points to the need for sleep hygiene. This is the standard stuff we talk with patients about: to sleep in a cold, dark room, establish a regular sleep-wake schedule, those kinds of things. And then CBTI, which is just CBT for insomnia. And this employs cognitive behavioral techniques, but it's also using relaxation techniques, biofeedback, stimulus control, sleep restriction, so it kind of envelopes all these modalities. And the other thing to consider is if you got this patient who's saying, well, you know, I'm feeling better now, but I'm still waking up throughout the course of the night, maybe consider screening them, use a PSG or actigraphy, but usually the insurance companies authorize for PSG, and make sure that they don't have some primary sleep disturbance that's just being exacerbated with the SSRIs. So these are just the acknowledgments of the people in the study. I want to thank Dr. Haynes as well as Dr. Bootson, who were very kind to take me under their wings. And if any of you see Dr. Brightboard, thank him as well for me, because he was very helpful with this presentation and all the research in the seminar. And I'll leave you with this quote about sleep. I guess we have time for questions.
Is there any difference between the various SSRIs?
Yeah, so fluoxetine has been studied the most, and they think that that causes the most amount of disruption. They actually, in the studies, have referred to Prozac eyes, a term for people having eye movements throughout the course of sleep, not just REM, even the non-REM stages. So right now, the current thinking is that fluoxetine is probably one of the most. Like I said, venlafaxine comes up even more than that. But we do know that they all have different pharmacological profiles, and so we would expect some differences. But there haven't been a whole lot of head-to-head studies. It's more kind of meta-analyses looking at, okay, this one looked at fluoxetine and placebo versus this one looks at citalopram and placebo, and they kind of compare it that way.
Do you think there's a role for nifazodone?
Yeah, I mean, I definitely do. Nifazodone, for the psych residents out there on the right, nifazodone and bupropion, it comes up sometimes. They're the only ones that increase REM, which kind of led to this whole dispelling of the theory of that REM is responsible for depression, because these antidepressants work and they actually increased REM. So I definitely do. I think the liver warnings have really shied people away from prescribing it, and it's kind of my same concern for when agomelatine gets used over here. But everyone seems to feel, and the studies actually showed that in some, along with gabapentin and Lyrica, it was one of the medications that could help consolidate sleep more into the slow wave sleep, which theoretically should be more restorative. So I think there's a good role. I just think that fear of the liver toxicity might be exaggerated, so it's not used as much. Okay, well, thank you very much. Appreciate it.